So if you had it 2 years ago, it's slightly different, and the topic is what do we do in the Mars 2 era? So these are not financial declarations of interest, but I am an investigator for the Mars 2 trial, so I might be biased for it. The evidence I'm going to present is the evidence that I have reviewed in the last 2 years as part of the British Thoracic Society Mesothelioma Guidelines Development Group. So the evidence for each procedure is going to be one piece of evidence, which is the strongest evidence. When the guidelines come out, which hopefully is going to be in the summer, you're going to see how this process worked. I am a network lead for a regional mesothelioma MDT, so when I refer to fantastic results from East Midlands, obviously there's a conflict of interest. And I am a surgeon, and I am quite vocal that I believe that surgery for mesothelioma works. In selected cases, under specific circumstances, but I think it works. Sir William Osler has had many famous quotes, but there's two that I think are relevant, that medicine is a science of uncertainty and an art of probability, and the greater the ignorance, the greater the dogmatism. So I know that we live in the era of evidence required for everything that we do, but sometimes we need to be able to produce knowledge and derive knowledge from existing knowledge without waiting necessarily for strict evidence-based trials. This is an updated slide compared to the standard one, and this shows the incidence of mesothelioma according to the Health Safety Executive. This is the latest one. This is last year's. And it looks like the disease is slightly peaking. So we're registering for 3 or 4 years, 2,500 deaths every year. And the line underneath it is the industrial compensation claims curve, and it looks similar. For England, for UK, not just for England, it is estimated that the disease will peak at some point between 2020, 2025, and then it's going to start declining. It's not going to decline rapidly because most of the people that develop the disease now are people who have been exposed to the construction industry. There are people who had small level of exposure, and they have very, very long lag periods. We now see mesothelioma develop in 50 or 55 years after a very short period of exposure. In contrast to what we were seeing 10 years ago, we were seeing mesothelioma developing after 20 or 25 years to shipyard workers. The National Lung Cancer Audit, which was published yesterday, very recently, last year, has shown that the numbers that we registered are similar to the ones that the Health Safety Executive has registered. And there are some interesting numbers there. If you look at what's happening across the country, there's great variability in how many patients will be discussed in an MDT. And you can see that my patch, East Midlands, has got the lowest in the country, which, frankly, I don't believe it, but it's what was registered with the National Lung Cancer Audit. You can see that radical surgery that happened to 0% in some areas, up to nearly 19% in our patch. And you can see that the only thing that is not hugely variable, but there is a variability, are the survivals. The percentage of patients that get chemotherapy also varies greatly. And when we're talking about surgery for mesothelioma, it's the standard 5 procedures I have been describing over the years. VATS, biopsy and periodicity, VATS decortication, open decortication, EPD, and EPP. But also there's a number of procedures that we do to stage the disease. And there's a number of novel procedures, like photodynamic treatments, or a number of palliative procedures, like airway or esophageal stenting, that are all parts of what we will do for the disease. For the purposes of this presentation, we're concentrating on the top 5. So, VATS biopsy and talc. We all do it. It's simple. We do a simple port. We're going to get biopsies. We're going to treat the pleural effusion, and that's that. The advantages is that most of the people can have it. The disadvantage is that you cannot do it in trapped lung because you have a risk of infection. The other advantage for me that I do radical surgery is that it makes my life easier when I go in to take the tumor out. I'm not particularly fast if it's a medical thoracoscopy or a surgical thoracoscopy because I don't see any difference, frankly. The only difference is if you have a difficult tumor to diagnose, which happens in mesothelioma quite frequently, you might have to repeat a surgical thoracoscopy. Where is the evidence that this is better than bedside prosthesis? The only evidence is a randomized study published in 2005, which have shown that talc insufflation via thoracoscopy compared to bedside prosthesis with talc slurry have similar results. So it's not necessarily better. So shall we do it? We need to do it because we need the biopsies. And we need to have a biopsy before we give chemotherapy, before we give any treatment. So a clinical diagnosis of mesothelioma is not very good. A cytological diagnosis of mesothelioma also is not very good because we need to subtype the disease. It's a completely different disease if you're dealing with sarcomatoid and completely different if you're dealing with epithelioid. So although there's not much evidence that it's necessarily better than doing bedside talc, we do need to do it because it will provide us with a diagnosis which is going to inform the prognosis, is going to guide the treatment. That's splenectomy decortication. 2 or 3 ports. It's more a visceral decortication than a parietal prorectomy because you can't really decorticate the mediastinum and the diaphragm. And this is one of the disadvantages. You can do it to elderly patients. You try to achieve lung re-expansion because the principle is that this way you might be able to treat the shortness of breath. Does it work? We have one randomized trial, the Mesovats, which has reported, and it does not appear to be doing much. There was no improvement in the symptoms other than a specific symptom in months 3 and 9, but not in months 6 and 12 after prosthesis. There's no improvement in survival. It costs more. It's associated with more mortality, associated with longer length of stay in the hospital. There's a new trial coming, Mesotrap, which is going to deal with the trapped lung, and on which this operation will be a part of it. But if you ask my personal opinion, if it's something that we should be doing, I don't think we should be doing it. There was a role for it in the era of the EPP, that you could not do an EPP to anybody older than 65. But nowadays, you have other procedures. You might as well offer an IPC to the patient. Mesotrap might answer that question, but it's still something which is on the cards, and it's in the design phase, so we will know. Simple prorectomy decortication is what most of the people are doing, not only in the UK, but around the world. You open the chest, you debulk as much disease as you can. You do leave gross disease behind because you do not remove diaphragm and pericardium, and diaphragm, particularly the diaphragm, will always be heavily involved. It aims to debulk the disease. It aims to re-expand the lung. It might get better lung re-expansion, but if we accept that macroscopic clearance of the disease is what we should be doing, then it does not appear to be a very good procedure. There is no randomized trial that compared it with anything, but there are systematic reviews, and there's a number of them. So the best evidence for this is this systematic review published by Cow in 2013, which very, very clearly demonstrates from retrospective studies, so this is level 3 evidence, that if you are to go in and do something, do a radical. Do not, because not doing a radical does not necessarily achieve much. If you ask me if I would ever offer to a patient as a procedure that I would offer as the intention to treat, I would not. I still do it in 1 in 10 or 1 in 20 cases if I'm in and I find that the tumor will not come off the SVC or the IVC or the subclavian vessels or the aorta, which are the usual sites of resectability. So if I've done the thoracotomy and I've decorticated half the chest, then yes, I will spare the diaphragm and not remove it because whatever it does, but I would not set off to do that procedure. And the new king of the procedures, the EPD, according to my opinion, It's extended pleurectomy decortication according to what the International Mesothelioma Interest Group wanted us to call it. It removes all macroscopic disease from the chest. There's a convention that you can leave a 50p coin-sized tumor. I do not leave a 50p coin-sized tumor. When I say all, I mean all. It might take hours, but I believe that you should aim to remove all disease that you can see. It spares the lung, and that's the biggest advantage, because the pneumonectomy adds an awful lot to the procedure. It does achieve macroscopic clearance. We had the arguments amongst the community that operates on mesothelioma over the years that if you have really bulky disease invading the lung, you will need to do an EPP. I don't believe that this is true. You can achieve macroscopic clearance. You might need to do very extensive dissection, skeletonize all the PA when you go into the fissures, but you will get it. The disadvantage is that it introduces the air leak as a problem, and the prolonged air leak introduces the risk of pleural space infection. And you cannot treat the hemithorax with all hemithorax radiation like you can do with the EPP. Again, the evidence is only level 3 retrospective studies, systematic review of these, which has shown that the EPD is a procedure which is associated with encouraging results in retrospective studies. But because we did not have any randomized control trial evidence, then we felt that we should see what is it doing. The reasons for doing it, for which we don't have evidence but they make sense, is that mesothelioma is not lung cancer, so the lung is not affected. You can spare it. Pneumonectomy is a disease in itself, and this is something that every time I say it, Professor Sugarbaker gets upset. But I do believe that removing the lung on top of an already large procedure is not necessarily a very good thing for the patient. If volume of disease is associated with the prognosis, and we use the volume of disease for the RECIST criteria when we give chemotherapy, reduction in the volume of disease is something that we consider success of treatment when we treat these patients with chemotherapy. And also, the total glycolytic volume on a PET is by some groups employed to use as prognostic factor. So if all this, if we think that the volume of disease is really important for the prognosis, then removing all macroscopic disease might make some sense. And as some oncologists say to me, the only thing that gets complete response to treatment, it's not chemotherapy, is an EPD, because it's the only thing that removes all volume of disease and sort of resets it to the minimal volume at the cellular level. So, MARS-2. We opened in June 15, and the aim of MARS-2 was to assess the role of extended pleurectomy decortication in treatment of mesothelioma. The design is take some of the chemotherapy regime from MARS-1, so 2 cycles of chemotherapy and repeat CT scan of the patient. If the patient remains resectable, even if the patient progressed on chemotherapy, the patient gets randomized to either surgery, which is an EPD, or no surgery, which goes to have another 4 cycles of chemotherapy. The feasibility aimed to recruit 50 patients in 2 years. We achieved that in 18 months or so. So we have now applied for the main trial, and recruitment continues. There's going to be, the trial management group in the January meeting decided there's going to be 4 centers across the country. The existing 2, Leicester, Sheffield, and then London, which opens soon, I believe, and Glasgow. And the methodology we've already described. All disease will go into MARS-2, even sarcomatoid is included. The only exclusion criteria is somebody who's unwilling to be randomized, unresectable disease, obviously. Performance status worse than 2, they cannot really take the operation. I don't think that I've seen anybody with a TLCO less than 20%. End stage CKD requiring dialysis, liver failure, pretty standard stuff. And when we select for EPD, basically, we need somebody who's going to have a normal cardiac function and a sterile pleural space. I put as relative contraindication sarcomatoid, although it's included in MARS-2, because I do not offer surgery for sarcomatoid outside MARS-2. I don't believe that surgery for sarcoma Audit works, and the respective results I have looked at are not encouraging. Progression in chemotherapy is a bad prognostic factor, significant progression in chemotherapy. It shows you that the disease biologically is aggressive. It's unlikely that even surgery will control it, even if it remains resectable. In MAS2, though, you would still resect because the trial specifically dictates to do so. Absolute contraindication in infected space. There are ways to deal with the patches in infected space. I would not recommend anyone trying to do an EPD in an infected space. It's going to be a bloodbath. It's going to be a postoperative space infection. It's unlikely to have a favorable outcome. And usually, the disease is unresectable on the right side in the IVC, the SVC, and the subclavian vessels, and the left side, station 5 lymph nodes might invade the window or the middle of the aorta for some reason that I cannot explain, but the usual R2s are there. Disease can be more difficult to resect the longer you are from the pleurodesis. So the more time that has lapsed between the TAC pleurodesis and your resection, the more difficult it is. And it's an absolute nightmare if you're resecting after 6 cycles of chemotherapy, 6 months or 1 year down the line because of the fibrosis. And most of my incompletes are that group of patients. The operability have to do with the fitness of the patients, and we've already visited that. This is a retrospective study that is from a lot of patients. We have showed retrospective analysis that EPD is not inferior oncologically to EPP, and therefore there is some rationale in doing it. But this is also very important. So when we looked at all of our patients, we have found out that adding chemotherapy to the radical surgery makes a huge difference. The median survival benefit is 10 months on top of what you might get with the operation. So if you get an X amount of time with the operation, adding chemotherapy would give you X plus 10. Most importantly, it did not matter when you gave the chemotherapy. There was no difference if you give it as an induction. There's no difference if you give it as adjuvant when you don't have any disease, or if you give it as palliative when you have visible disease progression. These are small subgroups, but the whole group of patients is fairly large. In the near future, the EORTC trial had surgery and chemotherapy on both arms, but it aimed to examine when to give the chemotherapy and whether chemotherapy could be best given before doing an EPD, or first you do an EPD and then you give it as an adjuvant. There were some delays. I've checked when I was preparing that, and it comes up on the clinicaltrials.gov as having had approval in autumn last year. So I suspect that they will start recruiting soon. The primary outcome measures will be full treatment, meaning achieving the chemotherapy and the EPD, and the patients to be alive and disease-free at week 20. Without any persisting grade 3 or 4 effects for chemotherapy. And the secondary outcome measures will be obviously survival, locoregional recurrence. And finally, the bad boy, the operation that was used for many years and is still used by some people around the world, the EPP or pneumonectomy, an operation which some people claim that can achieve R0 resection, but all evidence that we have is that very few patients actually might had R0 resection, and there's questions to be asked about how complete the examination of the margins were by the reporting pathologists in these occasions. It does give you maximum cytoreduction. It's an easier operation to do that in EPD because you do not have to decorticate the lung. So you just take the lung out and you throw it away. So technically, it's significantly faster and easier. The empty hemithorax can be treated with high-dose radiotherapy, and the high dose is high dose. It's usually, I think in mass it was 12.5 gray at least. And it's not complicated by air leak, not until you develop the tracheoesophageal, the TOF, when the stump breaks down after radiotherapy. People say that it's not suitable for N2 disease. It adds pneumonectomy to already major operation. There's an awful lot of problems with the space, and virtually all the patients will get some complications. Okay. In all this reported series, more than 50% of the patients consistently have serious complications. The evidence for that was the original MAS trial, and this is the only randomized trial, although the numbers were small and there were limitations, so there was criticism, that has actually shown that pleural pneumonectomy potentially harms the patients. And when we thought that it was all dead, some people from Canada have taken a whole new approach to things, where they give IMRT, 25 gray, plus 5 more to the areas with larger volume of disease, and then they resect the lung within 6 plus or minus 2 days from the operation, from the radiotherapy, sorry. And their results are really good. And they are not very, very selective because, as you can see, 94% of the patients are stage 3 and 4, and 52% of the patients have node-positive disease. So when I was discussing this, people asked me if I want to resurrect the EPP, and I said that no, because I don't think that EPP is a good operation for mesothelioma. But some people have produced some evidence, and we do need to see it. The controversies is if we should offer surgery only within clinical trials, and we have a conversation on many occasions with Mars too. There's arguments for and against. Argument for only doing it in trials that surgery might be harmful. There's no RCT-derived evidence. Arguments against is that patients need to have a choice, and also that there's other novel surgical treatments that would not necessarily be what MAST2 is. And the bright future of surgery is that we need to do things that we can audit and have quality control, and we need to be open about what we achieve and where our failures are, because life's short. Thank you.
Thank you, Apo.